Three stories. Daryl Mesho was 78. He arrived by ambulance at a Fredericton emergency room and waited about 7 hours. He was not called in. He was found unresponsive in the waiting room. He had died. Laura Hillier was 18. Leukemia. A donor was found. The transplant was possible. The bed was not there in time. She died waiting for the system to fund and deliver the care. Michel Houle was 72. He needed cardiac surgery within 2 to 3 months. He died on the waiting list. Months later, the call finally came to book his surgery. 3 stories, 3 provinces, 3 different points of failure. Not the same disease, not the same hospital, the same bottleneck. Canadian healthcare is not free. It is prepaid through taxes. You rarely pay at the door, but many patients pay another way, with time, pain, deterioration, uncertainty, and sometimes with the chance that care arrives too late. These are not isolated stories. They are warnings. The promise. In 1966, Canada made a promise. Medically necessary care would be based on need, not wealth. That promise still matters. It is one of the best things Canada ever tried to build. But coverage is not access. A health card is not an appointment. A referral is not treatment. A waiting list is not care. We already spend heavily. The OECD puts Canada at about $7,300 per person, adjusted for purchasing power. Kai projects total Canadian health spending at about $399 billion in 2025, or about $9,600 per Canadian. So this is not a story about Canadians demanding something for nothing. We pay a lot. The harder question is why one of the world's higher spending universal systems still leaves so many people waiting. By the OECD's count, 9.1% of Canadians reported unmet healthcare needs. The OECD average was 3.4%. That gap is the story. To understand it, follow the patient. The front door. Most planned care in Canada starts at one place: primary care. A family doctor, nurse practitioner, or regular clinic is supposed to be the front door. That is where symptoms are tracked, tests are ordered, referrals are made, and small problems are caught before they become large ones. But millions of Canadians do not have that door. Kai estimates that about 5.7 million adults and 765,000 children and youth still do not have a regular primary care provider. Even for people who do, timely access is weak. In 2024, only 27% of adults with a primary care provider could get same-day or next-day care for a non-urgent primary care need. That matters because medicine is not just one visit. It is pattern recognition over time. A walk-in clinic can help with a refill, an infection, or a rash. That is real care. But the doctor may not know your history. Your records may not follow you. The slow change, the recurring symptom, the missed test, the family history, the small red flag that becomes obvious only across several visits. One-off medicine is not built for that. When the front door is missing, people wait, improvise, delay, or go to the only door that cannot legally turn them away. The overflow. The emergency room becomes the backstop for everything the rest of the system could not absorb. That is not what emergency medicine is designed to do. In 2024 to 2025, Canada had more than 16 million reported emergency department visits. About 1.2 million visits ended with patients leaving before being seen and assessed by a physician. About 1.5 million people spent more than 14 hours in emergency departments. This is what overflow looks like. A person without primary care goes to the ER. A person waiting months for a scan gets worse and goes to the ER. A person who cannot access after-hours care goes to the ER. Then the ER fills with people who should have been treated somewhere else, earlier. Sometimes even the emergency door cannot stay open. Since 2019, Canadian emergency departments have been closed or reduced for more than 1.1 million hours, with closures concentrated in smaller and rural communities. These are not symbolic closures. They mean the building may be there, but the safe staffing is not. Too few nurses, no physician coverage, beds blocked because admitted patients have nowhere to go. Teams stretched so thin that staying open would itself become unsafe. The next town inherits the load. That is how a system loses slack. And without slack, the emergency system stops being a safety net. It becomes the place where every upstream failure arrives at once. The queue. For care that is not treated as an emergency, there is the queue. In 2025, the median wait from GP referral to treatment was 28.6 weeks. In 1993, it was 9.3 weeks. For orthopedic surgery, the median wait was 48.6 weeks. For an MRI, the national median was 18.1 weeks. In Prince Edward Island, the MRI median was 52 weeks. That last number matters. An MRI is often called non-urgent, but non-urgent does not mean harmless. It can mean a person is still walking, still working, still living with pain, weakness, numbness, or uncertainty while the diagnosis waits for the machine. The system does move quickly when it decides the case is urgent. Radiation oncology waits are closer to 4 weeks. Medical oncology waits are under 5. So the issue is not that Canadian healthcare cannot move. It can. The issue is that it moves for the cases it has already classified as urgent, while too many other patients deteriorate in the gray zone between not dying today and not safely cared for. That gray zone is where Canada stores scarcity. Part of the problem is how hospitals are funded. Many Canadian hospitals still operate largely under fixed annual budgets. Once the budget is set, extra patients are often extra cost, not extra revenue. The hospital can be full, the need can rise, the wait list can grow, and the funding formula does not automatically follow each patient through the door. A queue is not only a line, it is a budgeting device. It hides the shortage by spreading it across time. SecondStreet.org used Freedom of Information requests to ask a question governments do not routinely publish. How many people died while still waiting for surgery or diagnostic scans? For April 2024 to March 2025, the answer was at least 23,746. That number needs to be handled carefully. It does not prove the wait caused every death. The data are incomplete. Some provinces and categories are missing. But the basic fact remains. Tens of thousands of people died while the system still had them in a queue. Delay is not neutral. A major BMJ analysis found that, across several cancers and treatment types, each 4-week delay in cancer treatment was associated with a 6 to 13% higher risk of death. That is what time can cost. The wall. Now comes the part Canadians often discover only when they are already scared. If the public queue is failing you, buying insured hospital or physician care privately inside Canada is often banned or heavily restricted. The reason is not mysterious. The rules were built to protect equal access, care by need, not by wallet. Governments feared that a parallel private market would pull scarce doctors, nurses, operating room time, and diagnostic capacity away from the public system. That goal is serious. It should not be mocked. But a fairness rule becomes harder to defend when the public system cannot deliver timely care. Across Canada, the Canada Health Act and provincial laws largely eliminated user fees and extra billing for medically necessary hospital and physician services. In Ontario, taking payment for an OHIP-covered service is illegal, so a person may pay thousands in taxes for the system, wait months inside that system, and still be told they cannot legally buy the same insured care at home. That does not eliminate two-tier healthcare. It relocates it. In 2025, the Fraser Institute estimated that about 105,529 Canadians traveled abroad for non-emergency medical care. Some were seeking faster care, Some were seeking procedures or technologies they could not access in time. Some were simply trying to get back to their lives. That is the point. When Canadians leave the country to buy care, they are not escaping the cost of healthcare. They have already paid into the Canadian system. They are paying again because the first payment did not buy timely access. We did not abolish two-tier care, we exported it. The benchmark. Is waiting the unavoidable price of universal healthcare? No. Japan proves that. Japan has had universal health insurance since 1961. It covers hospital care, outpatient care, mental health care, prescription drugs, home health care, and dental care. Patients have broad freedom to choose providers, and Japan does it while spending less per person than Canada. OECD data put Canada at about $7,300 per person. Japan is about 5,800. Lower cost, broader covered benefits, better access to the machinery of care. Japan's preventable mortality is 86 per 100,000, compared with 126 in Canada. Treatable mortality is 49 per 100,000, compared with 58 in Canada. The lesson is not that Japan is perfect. No system is. Japan has its own pressures: aging, workforce strain, regional variation, and overuse risk. But on the central Canadian excuse, Japan destroys the argument. Universal coverage does not require chronic delay. Capacity matters. Japan has 12.5 hospital beds per 1,000 people. Canada has 2.5. Japan has 184 CT, MRI, and PET scanners per million people. Canada has 26. That is not a small difference. That is the physical infrastructure of access. If the scanner exists, the scan can happen. If the bed exists, the patient can move. If the hospital is paid in a way that does not punish extra activity, the queue can shrink instead of becoming permanent. Japan is not the only comparison. South Korea has universal coverage, high hospital and scanner capacity, and rapid diagnostic throughput. Sweden writes maximum waits into law. Contact the system immediately, primary care within days, specialist care within 90 days, and treatment within 90 days after the decision to treat. If a region cannot provide care within the guarantee, patients can be directed elsewhere. Germany and the Netherlands do better than Canada on same-day or next-day access when people are sick. These are universal systems. That is the key point. The waiting is not the price of covering everyone. It is the price of underbuilt capacity, weak primary access, fixed budget bottlenecks, and too few release valves when the queue becomes unsafe. What happened, Canada? Canada built a beautiful promise and then let the machinery underneath it fall behind demand. We protected the principle of universality, but we tolerated a system where access often depends on endurance. That is not compassion. There is nothing compassionate about a man dying in a waiting room chair. There is nothing fair about a young woman with a donor ready, waiting for a funded transplant bed. There is nothing efficient about calling a dead man to schedule surgery. The promise is still worth defending. Care should be based on need, not wealth. But the promise has to reach the patient in time. Coverage is not access. A health card is not an appointment. A waiting list is not care. Canada does not need to abandon universal health care. It needs to rebuild it around access. More primary care, more diagnostic capacity, more beds, funding that follows patients, public guarantees with consequences, a legal release valve when the queue becomes clinically unsafe. Other universal systems show that better is possible. Expecting better is not anti-Canadian. It is what a serious country does when a cherished institution stops working the way it was meant to work. We built this system, we can rebuild it. And Canadians are allowed to expect more than a promise on paper. They are allowed to expect care in time.